Let's dive right into it. Jim, you've done extensive work on understanding variation in health and outcomes across the US throughout your career. Now we are in this pandemic. So, specifically related to the COVID-19 pandemic, what variations have you seen for those at risk for acquiring COVID-19? And what can we learn by studying this variation, and what do we still have to learn?
Well, thanks, Vikram. I think in this map you can see here of the United States, early in COVID in March of 2020, we studied the prediction of who was going to die from COVID back in March of 2020 using Medicare claims data. And unfortunately, our predictions came true. Most of these red areas had high risk of mortality because of comorbidities. And what's really interesting, even today, we looked at the risk of not getting vaccinated also is high in these areas with very low rates of vaccination despite being at high risk for mortality. I think these atlas kind of maps that show the utilization and demography of our healthcare system allows us to plan better and hopefully execute better, but today we're still not doing it.
Yeah, I've learned a lot working with you, and what's interesting is you bring experience as a spine surgeon, a world-renowned spine surgeon, and then later running a fairly innovative health system at Dartmouth. So we know that we need to bring together the right set of people like you and others, the right set of capabilities and assets. So these types of data sets and so on. And then also the right set of technologies together to positively transform the practice of medicine and delivery of care. So how do you think about striking the right balance between investing in technological innovation and in human and institutional capacity building?
Yeah, well, I just show you some more slides here, Vikram, because I think technology is advancing quite a bit. But I think you can see from this slide, which is the same kind of zip code maps where we actually look at economic indicators. And places like Seattle, where Microsoft's headquartered, actually have gotten a little better in economic index of distress. But places like Alabama at the top there have gotten a little bit worse. So despite having the technology to inform people of these inequities, we haven't done much to change them. And so I think here is the opportunity, and I know that next panel will be talking about some of this, but here, when you think about cardiac disease and you think about those inequities in Alabama versus Seattle, and you take something like food insecurity on the left here, and look at the Hispanic populations actually having fairly significant food insecurity compared to blacks and certainly compared to whites. And then on the right, you look at the quality indicators or hospitalizations that are preventable. You can see that black patients have much more preventable rates of hospitalization, and I would argue that food insecurity is part of that problem. So we have the technology. We need to apply the technology and visual schema and data analytics to help our populations and those managing populations do it much more equitably.
Yeah, this is actually quite stark. And I assume that this is not just the case in the US. We are seeing this everywhere.
Yeah, I think this is a global pandemic, right? That's not just about COVID. What my fear is that with COVID will actually widen the digital divide between the haves and have-nots, and the health issues will become even more acute for the have-nots. Food insecurity was getting better before COVID, and now it's almost returned to pre-COVID levels, which is not good, and it's going to take us a while to catch up.
Yeah, you just referenced the upcoming session, which is focused on strategies for combating disparities in disease treatment, particularly in cardiovascular disease. What gets you excited about the set of experts that we have convened for this panel, and about what the possibilities here
Yeah,
are for
I'm
treatment?
really excited, Vikram, to have such a great group who have a global perspective on cardiovascular disease. This slide that I've shown you was just to lead up to that discussion because, it's one of the highest mortality and morbidity rates in the world, cardiovascular disease. We haven't made much progress, unfortunately, as I said. Social accountability is also a problem. And then when you think about the hospital-based approach versus the outpatient approach, with new technologies, I think we can do this better in the home and out of the hospital, which is the place that most people don't want to be anyhow. So I think technology is going to be an advantage here and a game changer.
Yeah, I think there are a lot of places in the world where there are no hospitals, even if you wanted to go to them. And so the ability to figure out, how to. Oh, and the other thing is that a lot of the signals for cardiovascular conditions are not hyper sophisticated. They're very simple signals. Blood pressure, taking the blood pressure the right way, etc. So I think there is a lot of potential here. So thank you, Jim. It was really great catching up with you as
Yeah.
always. And I'm now going to turn it over to our Health Futures colleague, Miah Wander, to kick off the
Thank you,
panel.
Vikram.
Thanks, Vikram and Jim. I'm Miah Wander. I'm a principal researcher at Microsoft Research with a background in the development of new medical devices for monitoring and diagnosing patients with cardiovascular disease. Given my interest in the space, I'm both humbled and excited to be with this group today, listening in on the conversation as we discuss opportunities for AI and other technologies to play a meaningful role in driving toward more equitable health outcomes. We have the great opportunity today to hear from Dr. Aerts, head of the Novartis Foundation, Elena Bonfiglioli, Microsoft's own lead for health and life sciences in Europe, Middle East, and the Africa region, and Dr. Sujoy Kar, the Chief Medical Information Officer and Vice President of Apollo Hospitals. Today, we're going to be focusing our discussion on health outcomes disparities in cardiovascular disease in particular, and we're going to do this for a few reasons. First and foremost, it's clearly a big problem. CVD is a dire issue globally as one of the leading causes of death worldwide. Second, it's a clear example of systematic differences in outcomes based on a patient's race or other characteristics. And third, which is a bit of a silver lining in my book, is that it's a venue where we've seen fantastic innovation over the past few decades in everything from diagnostic algorithms to novel treatments. So there's a clear opportunity to make some big changes, and I'm excited to hear from this group as to how you all think we can make that happen. So just kicking it off and jumping in, by way of introductions, can you each tell us briefly how you became interested in using technology to combat cardiovascular disease and health disparities, and let us know a little bit of how this has impacted the work you and your organization do today. Anne, would you like to begin?
Yeah, thanks, Miah. I think my interest in technology and health and care services dates from very long ago, in fact. It started when I was a young doctor and working as an emergency physician in conflict areas, in many areas, many countries around the world. And I was going on a bicycle. I was dropped by bicycle in the guerrilla zones in some African countries, and going on my bike from village to village to see the patients that the village health workers or the nurses had kept for us to see, because they couldn't reach hospitals anymore. The access was completely blocked. So I was risking my life with my bike on my shoulder, going through the rivers and all that. While now you can do that with a simple call. You can do it through telehealth. You can guide the village health workers through their patient care. And not only, you can use images, you can use WhatsApp to improve quality of care in general. And we've proven that in many countries, but the more mature models of telemedicine have really proven that you can solve 70% of the problems by phone if you need it. So imagine you need care when you're in a remote area, and now you have access to a digital tool to reach a medical doctor or a nurse, whatever you need. What a big difference this made. I've seen it with my own eyes and I've experienced it, so that's why I'm passionate about this.
Awesome. Elena, would you like to follow up?
Very happy to, and definitely not as intense of a story as Anne, which, thanks for sharing, very inspiring, Anne. On my side, actually, I come to healthcare with a health policy and economics background, and I've done a lot of advocacy work, really as the center point across my professional career in addressing major societal issues, from the time of working in accessibility to health equity and other issues that pertain really to sustainability of planet and people. So having the fortune of working at Microsoft now for the last 18 years, I think there is no better time and place to really match the opportunity of data intensity, which is really the context in which we live now, with the deep belief, which I really have, that data can save life. And there is definitely no better place than to apply the power of data to cardiovascular population health. So as a health policy, background, my hope is that in cardiovascular disease, we can really transform data-driven policy into real action and real impact.
Oh, that's fantastic. Two great facets, community and policy, that are going to have to come together. Dr. Sujoy, would you like to give us a quick intro as well?
Thank you again. Elena talked about the data part, and Dr. N talked about a personal experience. I would start from somewhere where both of these come together, particularly in different cardiovascular risk studies that have happened across the world. And we have the data to actually look at that. But what we found out was that there were some discrepancies or a cafeteria choice in how we were selecting risk factors, how the models were inaccurate in certain populations outside where they were actually built. And then they did not have a good reproducibility in prospective clinical trials. And people who would use this, tools would not get the kind of feedback in a way which would integrate their data for building or making these models more robust. And that is what inspired us to actually work with the data of patients to see over a period of time how we can build robust models and predict cardiovascular risk factors over a period of time.
Fantastic. That's great. Well, this is going to be a fun conversation. This is going to be a great group. So let's just jump right into it. We're all coming from different backgrounds, and I'd love to hear from each of you what you see as the right starting point. We've discussed data, policy, community outreach, algorithms. If we're going to really dig in and invest our energy in one space to start, either because it's low-hanging fruit or because it has high potential for impact, where do we begin? Elena, you want to take that one first?
Happy to. So first of all, let me say that where we began actually was the opportunity to work with kindred spirits, really, with people that have the same vision. I still remember the first time that I met Anne, and the passion and the clarity of wanting to have an impact, and doing that through collaboration and partnership is the space where we begin and we really drive the impact of making a difference. And working with world-class leaders and providers like Apollo and others, is really what is making the difference. And Microsoft is really at the center of being the enabler of, hopefully the invisible enabler, with real-world data that leads to real-world policy intervention. Now, for me, I think data is really at the center, because the moment in which you have the right data, you can get to the precision health delivery and the precision health discovery. And that continuous loop is really what can improve population health, both at the moment in which we deliver care, at the right time, in new novel virtual settings, and also how we accelerate research and discovery. And, would love to hear from other panelists, and then I'll share some stories of how we bring that to life.
Great. Sujoy, anything to follow up on that?
Yeah, I mean, Elena just said that she has to share a story, but we have our own story with Microsoft and Novartis Foundation working together in a consortium. But I think this is the beginning of the age of what we call as global algorithms with local factors. And this is where, the power of computing, federated learning, which is so very intense with using powerful tools like the Azure network, where you are able to build this, algorithms with the local data or local factors and test it anywhere in the world. We did it with Maastricht University with the help of Microsoft Azure, and then we are doing it in multiple other areas with the help of Novartis Foundation. What it gives is this, that it helps making the algorithms robust, go about global, looking at a solution from a cardiovascular disease in which you are making something more comprehensive, yet individualized, yet ethnically correct, and bring in the concepts of equity, whether you are looking at the gender, whether you are looking at the geographical variation, or whether you are looking at the age variations. And I would like to bring in Dr. Anne with that, because her perspective is the most beautiful one, if I know that.
So Sujoy, thanks a lot. And the point where I start from, I think, is really that cardiovascular disease remains the leading cause of death. And we've made tremendous advances, as you mentioned, as Sujoy also. In cardiovascular medicine, we have increased life expectancy really by 20 years or something. But the problem is that's not been equally the case in all countries or even within countries. We see that people from different neighborhoods, from different origins, from different ages have different cardiovascular outcomes. And we want to understand that better. So what better opportunity do we have than the fact that we live in a digital era where we have this computing power, where we can analyze and read through data from different sources. Because for me, what will be important to understand cardiovascular disease better and make the outcomes for patients everywhere similar will be that we understand what are the real drivers behind it. Is it only the genetics? We don't think so. It's probably also where a person lives. We know in Philadelphia, for example, you have a 25% higher risk to develop a stroke if you live in one part of the city with a certain zip code than if you live in another part of the city. And that is not acceptable anymore. So we have to understand these problems, the root causes of these problems, better by reading through data coming from the health sector, from the hospital and the clinical data, but also by reading through data from social and environmental determinants, because we know they play a big role. We know they are responsible for at least 35% of the problem. So this is the power of a partnership like ours, what Elena and Sujoy were mentioning, with the data collaborative between Microsoft and Novartis Foundation, Apollo initially, and Accenture. We are now working together to look at these varieties of data, to really drill down on what are the drivers behind the unequal outcomes in cardiovascular health. And that is going to be very much pioneering work, because it hasn't been done. And it will develop the insights, the tools for policymakers you were mentioning, Elena, so that they can better plan where they allocate the resources to, and make sure that the priority goes to the people who need it most. And that is the beauty of the era we live in today, indeed, where we have the power to analyze massive numbers of data and take learnings from there.
That's an awesome collection of answers. Please, Elena, jump in.
Yeah, and I think, Anne, you said it beautifully. What I wanted to complement with is that in addition to having cardiovascular as the leading cause of death, We are also in a very specific situation 2 years post the health crisis that we have experienced, in a bit of a syndemic situation in which waiting lists for cardiovascular patients have never been at such a high level. Just in the UK, NHS England alone, 250,000 people, with 50,000 people waiting actually for more than 18 weeks. So it's a trend that is 130 times higher than when we started this health emergency. And this is where novel modalities of collaborations, novel modality of healthcare delivery, but also the insights that data can give and point to the right interventions, maybe much more specifically for the right cohorts of people, are really yielding big benefits. And as I like to think about the hospital really entering the living room for cardiovascular patients as what has become a reality in such a fast pace, and we really need to be ambassadors for the benefits of it. When we think about some of the examples in Portugal, we have done some work with partners like Hope Care, in which a mix of digital solutions, video consultation, the right triaging powered by conversational AI and so on, have brought to a 48% of reduction in the number of days required for hospitalization, but also in a huge reduction of 85% reduction in emergency hospital episodes. So this is the power of that data intensity and digital modality that is driven by data. And this data collaborative, hopefully, can live up to those expectations.
Oh, that's fantastic. What a great story to get to tell. So that does a good job, I think, of mapping us through sort of data, research and innovation into a clinical setting. I'd love to know your thoughts on sort of the other lever arms that technology may or may not have an opportunity to wield in the broader ecosystem of healthcare. So payers, policy, some of the other moving parts. What are potential opportunities where technology can dig in and have impact there? And Elena, given your intro, I'd love to hear your thoughts there first.
Yes, with pleasure. First of all, I go back to my advocacy, which is really where I get the energy and the intellectual stimulus to really do this work. And I really think that technology has a huge equalizer power and role to play. So if we think about in imaging, for example, if we think about the opportunity to equip people that maybe don't have the skills to read an image and understand the situation of a patient, because the equipment is not there, or the capabilities are not as diffused as we have in many of the other areas. I think that this is where we can work with our partners, for example, like Ultraomics. We have worked with them with a solution that is called EchoGo, which is really making sure that echocardiography is read with the power of AI, and it goes to extend the capabilities of doctors anywhere they are. It doesn't really matter. So in that sense, equalizing on imaging would be one. Skilling people similarly with technology, with video, with the power of the ecosystem, and then patient adherence. That's the other area that I would like to call out, because in the moment in which we medicate, we also need to make sure that we have the right nudging behavior. We know behavioral economics shows that with the right companionship and nudging, we can really drive better impact. And here I think some of the work that actually Microsoft Research was incubating with the work of ADAS, with the health bot, and then brought to market and scaled up for the needs really of healthcare, could be a fantastic companion to in the shift from drug to treatment.
Awesome. And Sujoy, anything to add?
Yeah, I think it's really an important point you make, Elena, and it's not so simple to make it from the technology and all the beautiful possibilities we have to a rollout that is really impactful on the ground. We've seen that throughout our work in different cities around the world. We have a major urban population health initiative, and for example, in Sao Paulo, in Dakar, in Ho Chi Minh City, in Vietnam. And what we've seen is you need the data, you need the digital technology to mend the gaps in the health system. And you mentioned adherence. It's crucially important, and definitely in our settings here. But I can tell you that in settings where we work currently, in low and middle income settings, one other major need is really to identify people who have the problem of cardiovascular risk or cardiovascular disease much earlier, because they are mainly unaware. People don't know they have a high blood pressure because you have no symptoms until you do a stroke or a heart infarct. So it's really something that people have to proactively go and measure their blood pressure. So you walk through the hospital wards in Ho Chi Minh City, the big hospitals. They are completely full of people waiting. As you said, even in the UK, the waiting lists have increased. The University Hospital in Sao Paulo is the biggest hospital in the world, completely crowded, the corridors, people waiting to get an examination. What we did is we bring those screening opportunities outside of the health system. We trained shopkeepers, we trained supermarket owners, pharmacists, obviously also they are involved, but any kind of shopkeeper can do that, measure a blood pressure or even measure a blood glucose. It's feasible. And he or she can be trained on giving the right information. And that all is possible thanks to digital technology, because the technology is like the glue between the people, the screening corners or the screening shopkeepers, and the health system. So people who were screening positive would be automatically, through Bluetooth, being referred to the health system. This in Vietnam worked so well that it really decreased their waiting lists for people who had a serious problem, who didn't need to be waiting in those who need their blood pressure measurement don't need to wait in the hospital. Only the ones with a serious problem need to be there. So that really made this waiting list much better. And now the government has found that this is such a promising solution to bring services outside of the brick and mortar of the health system that they made it global national policy, So it is scaled throughout all of the other cities. And this is the kind of opportunities technology brings us as well. And then I have another example, but first I leave it to you, Sujoy. I'm sure you experience the same situations in India with hospital wards overcrowded and people waiting who don't necessarily have to be there, right?
Absolutely. And, 2 or 3 things that we found out in use of technology, and particularly levers important levers for technology are particularly in adopting AI, was that at the very design phase, you have to go and identify if this is going to augment the workflow for the clinicians, whether it is actually suitable for a particular use case that you are going to develop. And this is a very important aspect, that you do not develop any AI or technology solutions just standalone. It has to integrate with the workflow. The other very important thing in clinical AI, particularly in cardiovascular disease, what we have seen is the aspect of explainability. I, as a clinician, need to understand from the data scientist what and how the model would work, and then be able to explain the same thing to the patient. So if I say that the BP that has been collected, the blood pressure that has been collected by the shopkeeper or by the pharmacist, and the blood glucose that has been collected by any one of them, how do we integrate that data to give a cardiovascular risk over a period of time? Why do we say that it is high risk? Why do we say it is a moderate risk? So that is something very important to translate in form of that. So that is something where the technology must look at and move forward. The other thing is, in many ways, what we have been finding is the way a much more accurate, efficacious algorithms coming up in healthcare And we have seen in our own models how it continuously keeps on improving in that way. But I think at the end of the day, it is about the ease of use at the clinical setting, which is actually going to drive it to the last mile.
I really love it. And Miah, as when we think about Microsoft, right, with the mission to really empower people to achieve more, what Dr. Sujoy just mentioned in terms of empowering that workflow should be really at the heart of what we do. That's why, in the example that I was mentioning before with Ultraomics and their imaging EcoGo solution, they automated the analysis of left ventricular cardiac volumes imaging, and they saved 25% in the workflow time. And that, I think, is massive, right? That's the one indicator you really want to be behind. You really want to streamline and make sure that we scale up, because when you start adding up the numbers, really, then you can help. And similarly, when you think about Finland, where, for example, 70% of all the consultation are done with virtual modality, 60 million Teams-based consultations, not only in cardiovascular, but generally Teams-enabled consultations globally. I think we could bring that care tailored for cardiovascular into the living room and really help that workflow.
Yeah, I know I'm not supposed to bias the conversation too much, but I wholeheartedly agree with both of those points. As the complexity of these solutions grow and change, it's going to be clear that usability is going to be paramount. So kind of two related questions. So I'll throw them both out there at the same time, and you all can choose to answer whatever components you want. So the first is, what's going to be hard about this? What are the barriers that are going to be really challenging for us to overcome? Trust, technical capability, access, whatever. And joint with that is, we know that in all likelihood, technology is not going to be the panacea in and of itself. It's going to have to interact with other lever arms and other modes of impact. So let's collectively talk about that set of things right now. Is how does technology, fit in as part of a puzzle to help us solve some of these really challenging components of the problem of inequitable health outcomes in CVD?
Yeah, I think that's a really good question. It's not such a hard one, but if you look around the world, the thing that will be the most complex to change in a rapid speed, I would say, is the skills and the capabilities of the people, the workforce, and the government leaders to understand what you try to achieve with data and AI-driven insights and solutions. So leveling up the skills of people is absolutely crucial everywhere, not only in low and middle income settings, but also in high income settings. And I know Microsoft has a great initiative on that, launched by your president not so long ago, or during the COVID pandemic. I thought it was a really excellent initiative. But the second one that is going to be very difficult is that obviously you need to not increase the digital divide, but to decrease it if you want to work on equity and inclusion. And currently, there's still half of the world is unconnected to broadband. Let's not forget that. So if you don't have the infrastructure, it is increasing the inequities if we continue leveraging all these beautiful technologies, but we leave half of the world behind. That's not our goal either. And the third thing that is really crucial, which Elena and Sujoy, both you mentioned already, is you really need to include the people who will use the solution or the insight. They have to be included when you start thinking about designing it. Because if it doesn't get that buy-in, it will never be acceptable. And you will never have the correct processes to integrate. Because we all want what you mentioned, Elena, that artificial intelligence and human intelligence gives us better outcomes. That's the goal. So if you combine that together, we really have to make sure we develop the infrastructure, also the systems in countries for governance and regulatory, so that they keep people safe and data secure. That's also something everybody speaks about, but many countries simply don't know how to do it. So that's going to be a main barrier if we don't look at building, nurturing that whole ecosystem.
Fantastic. Any follow-up, Sujoy or Elena?
Yeah, I was thinking of 5, 6 things, and Dr. Ann had already ticked 4 out of the 6 things out there. And I'll just touch on the 2 very important aspects. One is, of course, for any technology, particularly if you're looking at clinical AI, particularly in use of CVD or other areas, how do you make the algorithm safe so that the outputs are something which are completely safe and have non-maleficence? This is something which is very, very important, again, at the design phase, to take out the bias from whether you are looking at it from the algorithm side or whether you are talking about from the output side, or how people use that. Even in their use, they could be biased in that way. So those are the things that you would have to factor in. And the second and the last thing that I would like to talk about in this context is Dr. Ann talked about human and machine. And, there are areas where humans would hand it over to the machine and machines will hand it over to the humans. How do you make those handovers seamless so that, nothing falls through those cracks, and ensure that it actually eventually goes and, helps in the clinical decision making for their patients, because you are actually devising these for the patients. So safety, non-maleficence, and the safe handovers from human to machines are some of the points that I would like to include here.
I love those points. And actually, I was going to make 2 comments, to your hard question, but if you allow me, it's going to be 3. So I think the first comment I wanted to share is, are we going to live up to the trustworthiness and so the responsibility of the AI that can really give us that productivity enhancement? And there, I think that the fact that Microsoft was very forthcoming in launching its Microsoft AI principles, around fairness, reliability, safety, privacy, security, inclusiveness, transparency, and accountability is paramount, because it's paramount in the way in which we think about how we develop those AI, those algorithms, and so on, and how we do the governance also. That is reflected in the second hard place, which we need to really be committed to, which is open standards and therefore interoperability. If not, we continue in a place of beautiful, shining solutions that don't talk to the other. So I think that Microsoft and the work that we have been doing in re-engineering Azure, really the work that Heather Cartwright's team have been doing in expanding our health data services, really to enable the exchange of multiple data type in FHIR format, fast healthcare interoperability resources format, is at the core of the data intensity and liquidity that will make all of this possible. So responsibility, interoperability, but the third one, Dr. Sujoy, you spoke about the experience. How do we make it a seamless experience? And for that, I think the keyword would be really process automation and understanding user behavior. So I would say maybe we didn't crack the code yet, but the launch of Microsoft Cloud for Health, in which the process has been automated and integrated. The fact that from a video call, you don't have to exit the application of the electronic medical record, but with a click of a button, you have a connector from Epic or others, and you can have your video call, a virtual waiting room for the patient. All of these things, will really make that seamless experience that hopefully also provides confidence and convenience.
What excellent points. I mean, that's a real tour de force of all the pieces that have to come together, I think, to ultimately find success in this space. No, it's good. It's good that we're owning that and we're addressing it, and that we have collaborations like we have amongst the 3 of you to bring together the interdisciplinary expertise that I think can make all of that go at the same time. So that's fantastic.
And Miah, sorry.
Yeah, please.
They are not here. But Accenture has done a great job. I really see them, as partners in this data collaborative. So really, it's been a long journey since we launched. And by the way, we launched at the same time as Microsoft launched the Open Data campaign, really in the spirit of those data collaborative. But just wanted to mention that Accenture also has been playing a key role together with the three of us.
Great, thank you for adding that in. So I want to go back to something, Sujoy, that you said earlier. I lost the exact turn of phrase, but it was talking about, I think, global data and local insight. Recapitulate that for me real quick.
Global algorithms and local factors.
Yeah, exactly. So I want to think now about global scale of the things that we build locally and drill in on that a little bit. Because, by definition, when you're prototyping things and building new things and evaluating their efficacy, you kind of have to start, within an envelope. And ideally, you want to then grow that and expand it and have as widespread of impact as possible. I'd love to know from the three of you what you think the keys are to being able to do that rapidly, but also safely and effectively. How do we drive for global scale? How do we build for global scale from the ground up as we're trying to innovate and change models of care that can address some of the disparities we've been discussing?
It's a tough one, right? I wish we really had that silver bullet. So I call it the glocality dilemma. It's really the glocality dilemma because the technology has the scale and the scalability, but the user requirements, a deep understanding of the local system and the local user requirements, I believe, is what makes the trick. So for me, I look at it not as a scale out, but as design for global after we have understood the real need and start from a very specific focused use case and then deploy with local relevance. So I really see it the other way around. And I think that the work that Anne and the Novartis Foundation have been spearheading in setting up a scientific committee for our data collaborative, making sure that we get different perspectives from experts of health systems around the world, different backgrounds, is very important because we have to come to that set of use cases that are global enough, but also then can be tailored. And the technology, as we know, has that scalability. So I don't think it's really a technology challenge.
No, I agree fully, Elena, and I think it's a data challenge. The technology will be global, but the data, when you have an insight that works in one setting, you still have to validate it with local data. That will always be the case because systems are different, as Elena says, but also people are different, and there's more mobility or less mobility, whatever. You have to use the local data to validate a solution that you build globally. And that's something we are thinking about now also with Microsoft to work specifically on this question of equity and in cardiovascular outcomes. If we want to develop the insight or an algorithm that can tell us what are the real drivers beyond these unequal cardiovascular outcomes, we have to build that in data-rich environments. We have to build that model where the data is present, like in North American cities or European cities or maybe a few other cities around the world. But then our goal will be to have those insights translated into local insights with adaptation and tailor of the model and the algorithms to the local data and the local systems to then again simulate what would have the biggest impact if you mitigate one or another of those factors. So it's really linked, the translation of the research, if you may, the building of the AI-driven insights into action is always going to be with the local angle. You will always need that. If you want to translate something into action, something that has tremendous evidence around the world, we know it with all the beautiful therapeutic options there are, they are not scaled if people don't see that it also works in their context. Policymakers, decision makers want to see that it also works in their context.
And the concept that I would like to add, and it comes from one of our partners as Maastricht University, Professor Andre Decker. And when I asked him this question, he replied by saying, it is a three-step process, Sujoy. The first is, of course, the validation, which Dr. Ann was talking about, where we are looking at validating it on a particular data set and see how well it is working. The second is the opportunity to calibrate it by bringing in the factors from that particular locality or that particular geographical or ethnic area and see what are those cardiovascular variables which are important for that population. And the third one is the co-creation. So you move through validation, calibration, and co-creation, where you are not just doing it for a scientific research, but also for the prospective use to learn more. And we know that the more we do the prospective use in all of these different communities worldwide, the algorithm is going to learn more and more and become much more robust in that way.
Yeah, and if I may add, Sujoy, I think that's a crucial step, this third one, because it's not only for the prospective use so important that you co-create with the people on the ground, it's also to make sure that you are bringing insights that answers their priority problems, because they may have a whole other agenda than the one we have developed in another setting. And we've seen that through our work in the urban population health initiatives. If you start your approach by listening to what the priorities are for the local decision makers, you will be by definition much more successful because they then own the whole initiative. And we've seen that happening in our initiatives where we use a cardio approach. In fact, I just want to say cardio is an acronym and it stands for quality of care, early access, what I mentioned before. The R stands for policy reform, the D stands for data and digital, the I for intersectoral collaboration, and the O is the most important part even, is the local ownership. If you don't get that local ownership, none of the solutions, how beautiful they may be and how well they all will work, they will get not scaled. So it is really crucial to have all these aspects thought about before you bring it to a local context. And I think we are doing well by looking at what are the local questions first and then develop it together, maybe in another context, but at least we know what kind of question we try to answer. That's the first step for me.
And then, hopefully, if that wonderful virtuous cycle, as Maastricht as described it, and Dr. Sujoy, as you shared with us, works, there is a fourth step, which is really that policy-driven approach that guides the system to become more effective and much more resilient. So that use of data, which empowers real-world policy, data-driven policy at the level of health system, I think would be the fantastic next step, because it can only happen locally,
That's our goal, with the data collaborative, that we get there, but that's really necessary, yes, absolutely.
Oh, that's fantastic. Well, I'm watching the clock. I know we have a packed agenda today, and I want to make sure we can get to the next session, get everyone to the next session on time. So I think with that's a great closing moment to think about the virtuous cycle and the many moving parts that have to come together for us to find success. I mean, you all have taken us through an awesome series of topics today, from the data that we're collecting and the way we go about collecting it, all the way through inclusive design from the ground up, and ultimately integration of AI into clinical workflows such that they're interpretable and readily usable by the community and by healthcare professionals. I could genuinely listen to this conversation go on for hours. But on behalf of the audience, I want to extend a sincere thank you to all of you for joining us today and for sharing your thoughts and your inspiring stories about where we can go and how we can really come together to address some of the disparities in cardiovascular disease and in the healthcare ecosystem all up. So a sincere thank you to each of you for joining us.
Thank you. It was a pleasure.
Thank you.
Thank you.